As far as inpatient treatment goes, although you will most likely initiate treatment for depression, the goal is not necessarily to get the patient into remission. The main thing you're doing for the patient is keeping them safe from harm to themselves and others, and starting medications so that they can follow up with a psychiatrist in the outpatient setting. Make sure that you talk to the patient about treatment expectations and goals. For example, medications for depression can take months for full benefits to be seen. Patients also respond differently to different SSRIs and SNRIs, and there's not necessarily a perfect medication for a patient. We're not going to go over all of the information listed in this table right now, but it will be available to you for reference later. Some important things to note are that SSRIs and SNRIs are the first-line treatment for major depressive disorder. As far as choosing which SSRI or SNRI to start for a patient, you might want to consider each medication's side effect profile and any comorbid conditions that the patient has. For example, a patient with neuropathy may benefit from an SNRI, such as venlafaxine or duloxetine. It's also important to note that SNRIs may increase anxiety temporarily in some patients due to its potential activating effect with norepinephrine. Regarding side effect profile, if a patient already has some GI issues, you may want to avoid sertraline. Consider starting a different SSRI with a lower chance of GI side effects, such as fluoxetine. With all of this in mind, make sure to check with your attending physician before starting any medications. Here are some second-line options for treatment of major depressive disorder. You may use these if a patient is reporting persistent or refractory depressive symptoms after an adequate trial of SSRIs or SNRIs. Some medications listed here are for augmentation of an SSRI or SNRI, such as aripiprazole. In this case, you would continue the SSRI or SNRI that the patient is already on and add on aripiprazole. Another important thing regarding dosing of medications is that more does not always mean more efficacious. For example, lower doses of mirtazapine can help patients more with insomnia versus higher doses.
The most common type of psychosis you'll encounter in major depressive disorder are negative auditory hallucinations. If it is only negative self-talk rather than true auditory hallucinations, treatment consists of an antidepressant alone without any additional antipsychotic. One way you can approach differentiating negative self-talk from true auditory hallucinations is to ask him if the voice sounds like someone speaking to them or if it sounds like a voice inside their head. If there is distressing psychosis present, dual therapy with both an antidepressant and antipsychotic should be initiated. There are many different medication options, so try not to get caught up in any right answer. Treatment with antipsychotics in major depressive disorder is typically temporary. Side effects should guide therapeutic decisions. So your next question may be, when do we decide if a drug isn't working and we need to switch? So if the original problem worsens with initiation of treatment, consider switching. If a patient develops serious adverse effects, stop the medication immediately. Things you should consider are medication withdrawal as well. If drugs are too dissimilar, patients could experience withdrawal. With medications that treat depression, withdrawal is typically uncomfortable but not dangerous. When switching from an SSRI to an SNRI, we reduce the SSRI to its starting dose and then switch the next day to an SNRI. Some medications have special considerations when switching. Venlafaxine can cause extremely uncomfortable withdrawal symptoms and will likely need to taper for weeks prior to switching agents. MAOIs are not commonly used anymore, but when switching to an SSRI, there is a 2-week washout period. This simply means you stop the MAOI, wait 2 weeks, and then start the SSRI. Also, avoid switching from bupropion XL 300 to 400 milligrams per day to fluoxetine or paroxetine, as these medications will increase bupropion, which will decrease the seizure threshold, raising the patient's risk for seizures.